Hello, do you hear
Hi.
us?
Hello, good morning, everyone.
We have a
Can you hear me?
fantastic picture of yours.
Okay, thank you. So I'm sitting just next to my patient, right side, and I'm prepared. I just prepared to check the ultrasonography for performing the percutaneous puncture. So, can I start?
So you're presenting EC here, so you're already in with the ureterorhinoscope, or?
Okay. Because this surgery is issues, then they already inserted the urethral accesses to the UPJ level, and I checked the renal pelvis.
Okay.
And this slide is about the patient's status, about the renal stone and kidney. So the most important thing is, there are two stones, renal stones, in the lower pole and the mid pole. And when I checked the mid pole stone, it was in the mid pole calyx, but it's not freely movable. So I think I need to use the flexible cystoscope after I remove the lower pole stones using the percutaneous nephroscope.
Okay.
And another important thing is liver is overriding the right kidney. So I have to perform puncture just below the river, and upward and to the patient's head. So a little bit oblique puncture is necessary, I think. So with my ultrasonography, if I puncture it directly to the lower pole kidney, then I think the liver damage may occur. So this is, we'll show the flank side. Okay. So using the ultrasonography to prevent the peri-organ injury while I do the puncture. So I check the kidney like this. So this is the kidney. So you can see some hydronephrotic calyx. And, okay. I need to change the, when I do this tapping, you can see, when I do this tapping, you can see the left side movement, so I change this, I change this probe. So while I do the tapping right side, the screen is moving on the right side. So that is the right direction to perform the renal sonography. So this is the stone, and you can see the posterior shadow of the stone. So I check the upper margin of anterior margin of the renal kidney. This is the posterior margin of the kidney, and this is the this is the lower pole, the tip of the kidney. So I mark the margin of the kidney like this, and I check the right place of the lower pole stone first, because I'll do the lower pole puncture. So here we can see the stone. And I move the probe upwards and downwards, so to check whether my probe is located in the right place. So I think this is the level of the lower pole stone. And I do the puncture just 1 centimeter apart from the right margin of the probe. So I check the level. So I'll make a little incision for needle insertion.
Do you always do ultrasound guided puncture, or you're sometimes fluoroscopical puncture?
Yeah, basically I started the puncture with my fluoroscopy, but from 2 years ago I tried to use the ultrasonography as
May I ask
possible.
the audience who's doing ultrasound guided puncture? Hand sign, please. Okay, not the majority. And who's only doing it with radiographic puncture? And who has the radiologist place the puncture? Okay, very good. I think to gain control over the whole procedure, ultrasound is always a nice tool. And there are also publications on ultrasound only, PCNL, which I think is also a nice procedure. But we can see the picture now, the stone and the ultrasound now very nicely.
I think the needle is just next to the stone. I can touch the stone now, but I think I need to find the space between the stone and the mucosa in the renal pelvis. So I feel the stone here. So maybe liver is overriding. So you can see the liver just next to the kidney, the ultrasonographic image. So I think that I feel safe during the needle insertion, so there must not be any injury in the liver. So I can touch you can see the needle right here, ultrasonography. Yep. So actually the urethral catheter is inside the kidney, and I fill in the contrast dye into the kidney.
So how will you perform the tract dilatation, with a balloon or with?
Yeah, with the balloon.
Okay.
Actually, because when you consider the cost effectiveness, I can use the metallic shears first. But in this case, there is a mid-post stone. Maybe I think this is quite difficult for me to approach to the mid-post stone with the rigid nephroscope. So maybe I need to consider the use of flexible cystoscope to reach the mid-post stone. So in that case, I need to use a large size. At least the flexible ureterus and nephroscope can be inserted into the kidney. So we need to consider the relative size of the percutaneous tract and flexible nephroscope. No contrast dye, but I think I need to find it. You can see the movable kidney. So whenever I touch the stone, the kidneys move together. I need to find the space between the stone and, oh my. Just in the center of the stone, the little tip is located. Okay.
I'm Dr. Zheng, come from Guangzhou. Nice to meet you.
Nice to meet you.
Last question.
Yes?
You always freehand puncture. You never use puncture guide. You never use ultrasound puncture guide.
I'm sorry.
Freehand. You always freehand.
Basically, I use the ultrasonographic puncture, so to check the location of the organ, and so I need to simplify my puncture technique. So now the thermal guide wire inside the renal pelvis, and of course it is easy for me if the thermal guide wire goes into the ureter. So I try it. So now thermal guide wire is going to the ureter, right? You can see a ribbon shape in the apocalyx.
Which sort of guide wire do you use for that?
Yeah, stiff type thermal guide wire.
Yeah.
And if I feel that the thermal guide wire is complete inside the ureter, then I can do this technique. When I retrieve the thermal a little, no, not yet. No, I'm sorry, not yet. So I retrieve the thermal a little, then we can see the straightening of the thermal guide wire inside the ureter. So now I'll put in the 8 to 10 French fascia dilator. So I call this, ribbon technique, but it's That's my preference. So please give me the knife, please. Knife, please.
So which will be the
So
actual
I
size?
extend the skin. I extend the skin incision. I'm sorry.
Which will be the final size of your access sheath?
You mean the percutaneous balloon
Yeah.
or accessories in the ureter?
No,
So
the
I'll use the 18 French balloon dilatation today.
Yeah. So your access sheath to the kidney will be 18 French wide.
Yeah, right. 18 French, and the scope is 16 French. So now the 8 French dilator is inside the ureter, and I'll put in the, okay, wait a second. 10 French dilator as well, because I want to put in the super stiff guide wire as a working channel, working guide wire. But I think I need to change the thermostiff guide wire. Although this is a stiff type, but I think it is less stiff. So it's supposed to be because the 8 French catheter is inside the maybe bladder, so it's available for me to change this guide wire from thermo to stiff, super stiff guide wire. Yes, after I change the guide wire, no, don't move the pedal. And I'll try the insertion of 10 French. No, still. Oh my. If it doesn't work, of course I can change the metallic dilator, but I'll try more. Okay, now it's in. So 이거 좀 잡아줘. So I remove the 8 French catheter. There you go. I'll put in the thermo guide wire again. Okay. Thermo is in the ureter, and thermo guide wire will be the safety guide wire for me. So I'll do the tubings. 넣어주세요.
So I asked the panel, does every one of you use a safety guide wire? I know from your talk from this year that you don't use it, Professor Zeng, but about the other. So Joyce, do you keep a safety guide wire for next to the access sheath?
So balloon
we try
dilatation.
to place one, but it's not always
5
possible.
French balloon 주세요.
You, Ahmed?
Also, I agree her. It's possible we can.
So whenever
insert.
possible you do.
Whenever, yes.
And you, Damien?
Yeah, similarly, Thomas, we're not so brave that we would do it without the
Location
safety
of
wire.
morning.
Yes, I'm a sissy. I always place
Nobody
a
helps. What are you
safety
doing?
guide wire.
So my nurse is preparing the balloon dilatation, 18 French plastic balloon. So of course the metallic, my preference is metallic dilator, but there's a matter of a combination of medical devices to approach all the stones.
My comment to safety wires in general is it's like with a safety belt. You don't need it in the car throughout your whole life except one day, and you are very happy if you're wearing the safety belt then.
Yeah, okay. This radio marker is just next to the stones, so I'll do the balloon. Go. Okay, so usually pressure reach to 18. So we can see the fully dilated the balloon. So now I'll put in the plastic sheath. So please grab it. Just. And now, so the plastic dilator is just next to the stone, so I remove the the balloon. Okay. Okay. So I'll check it. 이리게이션을 틀어줘야 되는데요. 이리게이션 안 틀었나 본데. 이리게이션 스타트 눌러주세요. Okay. So now,
You use irrigation pump for irrigation? You use pump for irrigation or not? You use pump for irrigation.
I'm sorry.
Pump for irrigation.
Yeah, apropos, but you mean the irrigation? I mean, I couldn't understand what you mean. So this is the local puncture, and irrigation is just next to the patient's head, and I'm sorry, so this is the stone. It's just next to the local calyx. So I'll, put a collector.
How to remove this
on the abdomen.
blood clots?
Yeah, blood clots, maybe. So just next to the stone. So usually these clots can disappear easily, so please give me the laser fiber. I'm using the 550 micrometer laser fiber. So this is available for medium-sized mini Perc from 15 to 18. So I think that we can, if we want to guarantee the surgical efficiency, as a 550 is appropriate. So give me the pedal. So the setting, please check the laser setting. Now I'll use the 2.0 zoom with 30 Hertz. Ready.
So which settings are you using? You're using high frequency, obviously. And what settings do you use for the holmium laser?
Yeah, basically, I'm sorry. I'll remove the super stiff. Basically, for mini Perc, I'm using the 2.0 zoom with 30 Hertz. But of course, the high frequency is a matter of efficiency to remove the fragmentation and retrieval of stones. So if we increase the frequency and power, the efficiency can be increased, but we have to consider the safety as well. And maybe it can generate some heating inside the kidney. So, I'm sorry. So I do the laser firing in a versatile manner. So I remove the stone like this. So if I do this backward and forward movement frequently, then I think that it can be helpful to reduce the intrarenal pressure. And this is the supine position, so I don't need any suction for retrieval of these stones, because stones can come out very easily, spontaneously through this track like this. We call this vacuum cleaner effect. And I collect the stones, just the bowl, on the patient's abdomen like this.
Very nice demonstration.
So I wanted to increase the efficiency, so I removed the working guide wire, super stiff, because I have another safety guide wire. Now, it goes out. So if it doesn't goes out, I do the laser firing just in front of the stone, then it can facilitate the stone moving outside the body like this. Oh my! Hey, come here. Okay. So if there is a hematuria, we have to increase the irrigation fluid movement. So it can make some increase of intrarenal pressure. So we have to carefully do the fragmentation to control the intrarenal pressure. Okay. Of course, if you want to decrease the pressure gradient, the table can be a little bit tilting to the right side, but stones goes well, so I don't do the table tilting.
Did you see in the supine position sometimes colleagues report that the system collapses because the outflow is too good? Have you seen this? Because this is a problem you would not see in prone position. Did you see that?
Supine position. If I use a suction, that the renal pelvis can collapse, but basically it doesn't collapse if we don't use the suction. And there's a matter of fluid management. So I don't feel any difficulty because of the collapse of the renal pelvis, renal collecting system. Okay, go out.
Oh, quite big.
If the stone is just next to the renal, at the end of outcomes, just next to the renal parenchyma, then we can see the hematuria. So we can modulate the flow of irrigation fluid to make the clear visual field. Okay. 네, 주세요. So I think they're almost all, okay, here. Almost all lower pole stones disappear. Yes. Yeah, almost all. Okay, here, the last one maybe. Flexible 주세요. Okay, I checked the location of the mid-pole stone. So almost all lower pole stones are gone. And this, okay, well, oh my God. I'm sorry, some small stones here. So I want to show you the use of flexible cystoscope. But time limit is only 5 minutes left. So, okay, I check the location of here.
I think you should not feel pressed by the time issue because you can summarize your patient. Even if you want to do flexible piloscopy for the upper pole, you should focus on full clearance, not on the time issue. I think we have seen a nice clearance of the lower pole as well as a nice access to the kidney. So whatever you choose to do, go ahead and don't look for the time. We will simply have to move on for the next sessions in a few minutes. So
yeah, okay.
So you would now normally go for flexible piloscopy, which you originally thought of. Is that right?
Yeah, this is because of the angle, I cannot reach to the mid-pole stone.
Yeah.
So maybe this is my time to change the scope to flexible cystoscope, nephroscope.
I think that is a very wise decision. And it demonstrates that one has to be flexible during surgery. And I think if you cannot reach it straight, I think one good advice is not to bend the sheath inside the kidney too much. Otherwise, you can do some forceful harm to the kidney. And you will cause bleeding. That's also true. In which percentage you use a combined flexible and semi-rigid approach in the kidney? Is that often or is that rather rare?
I'm sorry.
Here the panel, you use flexible?
Yeah, I always consider of course, I'm not sure I did understood the question, the meaning of your question, but I consider the combined procedure of mini Perc and flexible nephroscope or flexible ureteroscope according to the location of the stones.
Yeah.
But this situation, I think the distance from the lower pole to the mid pole stone is not so close. That I think the flexible nephroscope will work. So I try the flexible nephroscope first because we can guarantee the clear visual field using the flexible nephroscope. So usually flexible nephroscope first, but if there are multiple stones and small stones and some other, if there are some more factors, then I use the flexible ureteroscope through the ureter. But this time I think I'll try to change the flexible nephroscope to reach the mid pole stones. So I change the scope. Okay.
So, Olivier, you prefer flexible cystoscopes, which are used as nephroscope, or a digital ureteroscope? So, we have 1 minute left.
Yes.
So we need to finalize your session there.
Yep.
Do you have any final remarks on your case or on your strategy before we leave you?
My final message is simple because of course, we have to prepare every kind of medical devices and surgical techniques to prepare the tailored treatment for patients with renal stones, especially the number of stones are multiple. So I think we have to prepare this setting today. So I hope we can talk about this in the future. Anyway, sooner or later.
Thank you very much and congratulations to the nice surgery.
Thank you so much.